Let's talk about Opthalmia Neonatorum, also known as neonatal conjunctivitis. Neonatal conjunctivitis is defined as conjunctivitis which has its onset within the first month of life. So, if the signs and symptoms of conjunctivitis develop in a child after the first month of life, that conjunctivitis can no longer be considered neonatal conjunctivitis simply because the child is no longer a neonate, so it's not ophthalmia neonatorum. Right. So, what is ophthalmia neonatorum? It is the development of conjunctivitis within the first month of life. What is the mode of transmission of ophthalmia neonatorum? In most cases, in most infective cases, the mode of transmission is during passage in the birth canal, so during vaginal delivery. Alright, so how can we classify ophthalmia neonatorum? Ophthalmia neonatorum can be classified into aseptic and septic. The most common or the cause of aseptic neonatal conjunctivitis is secondary to the application of silver nitrate. This is a bit of an interesting story because silver nitrate has been used prophylactically since the 1800s to combat infective ophthalmia neonatorum. But sometimes, because of high concentration, the silver nitrate can irritate the eye, leading to a transient conjunctivitis which normally resolves within 24 hours. So, this is a very important differential of infective ophthalmia neonatorum. Moving towards the causes of septic ophthalmia neonatorum, the most common cause is chlamydia, right? And the most severe is gonococcal conjunctivitis. What about the agents? In the case of chlamydia, the culprit is basically Chlamydia trachomatis serotype D through K, because D through K are the serotypes which commonly infect the genitals, the genitalia. So, how do we know what is the infective agent responsible for a case of ophthalmia neonatorum? So, if the onset is pretty rapid, if it is within the first week and most likely within the first 3 days, what would be your differential? What would be your most likely diagnosis? If the symptoms of conjunctivitis develop within the first week and normally within the first 3 days, then we say that the most common diagnosis is gonorrhea. But if the symptoms develop within the first 3 weeks, right, and maybe on the 10th day as an average, then we say it could be chlamydia, it could be HSV2, which is a viral conjunctivitis, or it could be Staph aureus or pneumococcus. But what would be the most common pathogen we can think of if the time of onset is within the first 3 weeks, approximately around day 10? Obviously chlamydia, because chlamydia is the most common pathogen implicated in this particular kind of disease, which is ophthalmia neonatorum. So this is a very important point which can be mentioned in a scenario. So what else differentiates between chlamydia and Neisseria in terms of ophthalmia neonatorum? Ophthalmia neonatorum due to gonococcal infection is much more severe. In addition to being hyperacute, gonococcal conjunctivitis can be potentially sight threatening. It has the same mode of transmission from the mother during delivery, but the signs and the symptoms are much more severe. There is bilateral, extremely purulent conjunctivitis, and corneal involvement is quite common in gonococcal conjunctivitis, and this corneal involvement, this keratitis, can lead to the sight being threatened to blindness. Similarly, if it is chlamydial conjunctivitis, it is less severe, but it can lead to blindness, because not because of corneal involvement, which is rare over there, but because of the formation of a corneal panis, which is basically a lymphovascular infiltrate, and because of scarring of the conjunctiva, यानी कंजंक्टाइवा की स्कारिंग की वजह से क्लेमिडिया में भी ब्लाइंडनेस हो सकती है if not treated promptly. Then let's talk about viral conjunctivitis caused by HSV type 2. It has the same mode of transmission. Its onset is subacute, and in the case of viral conjunctivitis, there is blepharoconjunctivitis, meaning in addition to inflammation of the conjunctiva, there is also the involvement of the eyelid, and in HSV2, corneal involvement is pretty common. So these are the most important bits as far as neonatal conjunctivitis is concerned. Another super interesting point is that whenever they mention chlamydia trachomatis as a cause of conjunctivitis, three entities come up. The first one is trachoma, which is a chronic conjunctivitis endemic in certain areas. Then there is adult inclusion conjunctivitis, and then there is Opthalmia Neonatorum. In the case of trachoma and in the case of adult inclusion conjunctivitis, both of these conjunctivitises are considered to have a follicular reaction. In the case of trachoma, the follicles are present predominantly on the conjunctiva lining the upper eyelid, whereas in adult inclusion conjunctivitis, the follicles are found primarily lining the lower eyelid conjunctiva. Similarly, the presence of follicles on the bulbar conjunctiva is considered to be pathognomic, although rare in cases of trachoma. But in ophthalmia neonatorum, due to chlamydia, there is no follicular reaction because the child is a neonate, there is not enough lymphoid tissue. So again, some important